Okay, you did it. You graduated. Now let's talk about conquering the NCLEX. We're going to run through one of the most basic but crucial skills you'll use literally every day. IV therapy. Just for the next few minutes, think of me as your preceptor. We're going to walk through this just like we would on the floor, and we're going to hit all the things the NCLEX loves to test. Patient safety, critical thinking, and knowing what to do first. My goal here is simple, to make you feel totally ready for this. All right, let's just jump right into the deep end with a classic high-stakes NCLEX question. Picture this. You walk into your patient's room, they've got a PICC line, and all of a sudden, they look terrified. They're grabbing their chest, they can't catch their breath, their blood pressure is plummeting, and their heart is just racing. So, what is the very first thing you do? Don't shout it out just yet. Just let that question simmer in the back of your mind. We're going to build up all the knowledge you need to nail this, and I promise we'll come back to it at the very end. So here's our game plan. We're going to follow the entire life story of an IV, from the second the order pops up in the computer to the moment we safely take it out. We'll cover why we even give IVs, how to prep the right way, the insertion itself, how to spot trouble early, and of course, how to finish the job without a hitch. It's the whole shebang. So, Section 1, the order. We're starting at the very beginning. Every single thing we do as nurses starts with a provider's order, right? But the NCLEX wants you to think beyond just following that order. They want you to understand the why. Why does this patient, right now, need a line in their vein? Knowing that is half the battle. And it pretty much boils down to these 4 big reasons. 1, your patient can't take anything by mouth. They're NPO. 2, they need rapid replacement of fluids and electrolytes. Think of someone with severe dehydration. 3, this is a huge one in an emergency. It gives us a direct, immediate highway into the bloodstream. And 4, it's our best route for giving critical medications or blood. Understanding which of these is the reason for your patient's IV is key. Okay, so we've got our order, we know our why, now let's move on to the what. This is the prep phase, and honestly, it's so important. This is where we gather our solutions and all our supplies. Getting this part right before you even walk in the room is a massive safety check. It'll save you so much hassle, trust me. Understanding how these different fluids work in the body is a total favorite on the NCLEX. So let's break it down. Isotonic solutions, like your basic normal saline, have the same concentration as our blood. They just hang out in the vascular space and add volume. Easy enough. Hypotonic solutions, they're more dilute, so they actually push water into the cells to hydrate them. And hypertonic solutions do the exact opposite. They're super concentrated, so they pull water out of the cells. All right, time for a little NCLEX check-in. You've got a patient with some pretty bad burns. They've lost a lot of fluid. You need to replace that fluid in the extracellular space. What are you grabbing? A, B, or C? Think about it. Where does that fluid need to stay? If you said B, isotonic, you are spot on. A solution like Ringer's lactate is perfect because it's going to expand that volume right where we need it without causing any crazy fluid shifts. Nice work. And let's take a quick look at our tubing. You've got the spike, the drip chamber, the little roller clamp to control the speed, and the end that connects to the patient. Now, the single most important thing you do with this before anything else is prime it. You got to run fluid all the way through to push out every last air bubble, and we're going to see exactly why that's a life or death step in a little bit. Now, before you even start looking for a good vein, you have to know which arms are completely off limits. This is pure safety, which is NCLEX 101. Never ever use an arm that's swollen, weak, or paralyzed. Always avoid the arm on the same side as a mastectomy. That messes with lymphatic drainage. And absolutely stay away from an arm with a dialysis fistula or any skin that looks infected. These are hard and fast rules. No exceptions. All right, all our prep work is done. It is time for Section 3, the stick. This is the main event, the actual venipuncture. This skill is all about precision, staying clean, and communicating with your patient so they feel confident in you. Let's walk through it. First, prepare. Double-check that order, make sure your line is primed, and tell your patient what you're doing. Second, select and clean. Tourniquet on, find a nice bouncy vein, and clean that site like you mean it. Third, puncture. Hold that vein steady, poke, and watch for that beautiful little flashback of blood. As soon as you see it, drop your angle, advance the catheter just a bit more into the vein, and now, super important, pop that tourniquet before you connect your tubing and start the flow. Then you secure everything down. But wait, you're not done yet. You have to remember the golden rule of nursing. If you didn't document it, it didn't happen. As soon as that IV is running smoothly, you need to chart it. How many tries did it take? Where is it? What size catheter did you use? What's infusing and how fast? Get it all in there. Legally, professionally, it's non-negotiable. So the IV's in, the pump is beeping away happily. Now your job totally shifts. You go from doing stuff to watching, vigilant observation. This is where your assessment skills are everything. You are now the patient's early warning system for anything that might go wrong. And this slide shows two of the most common issues, infiltration and phlebitis. The NCLEX absolutely expects you to know the difference. Infiltration is when the fluid leaks outside the vein. The big clues: the site is cool, pale, and puffy. Phlebitis, on the other hand, is when the vein itself gets angry and inflamed. For that, you're looking for a site that's red, warm, and tender. So just think, cool and pale versus red and warm. That's the key. Okay, now for the really scary stuff. These are rare, but you have to be ready. An air embolism, which is why we prime our tubing so carefully, presents with sudden chest pain and trouble breathing. A catheter embolism, where a piece of the catheter breaks off, that can cause a weak, thready pulse and pain. And circulatory overload, from too much fluid too fast, will give you high blood pressure, bulging neck veins, and crackles in the lungs. You've got to recognize these signs instantly. All right, another pop quiz. Your patient is showing all the signs of circulatory overload. They're breathless, their neck veins are popping. Out of all the things you need to do, what are your absolute first moves? What are the priorities? Here is your order of operations. First, and this is the most important, slow that infusion way, way down, or just stop it. You have to cut off the problem at its source. Second, sit them up. Raise the head of the bed to make breathing easier. Then you get your vitals and call the provider. But it's always slow the rate, raise the head. That's your 1-2 punch that can save a life. Okay, we've managed the infusion, and now the provider says we can take it out. This brings us to our last section, finishing strong. Taking a line out isn't just an afterthought. It needs the same focus and safety-mindedness as putting one in. The process is pretty simple, but the details matter. First, clamp the tubing. Then, hold the catheter hub steady while you gently peel off the dressing. Place some sterile gauze over the site, don't press down yet, and then smoothly pull the catheter out, keeping it parallel to the skin. Now you apply firm pressure for a good 2 to 3 minutes. And remember, way longer if your patient is on blood thinners. And now for the most critical safety check of all. Is this right here. You need to look at that little piece of plastic you just pulled out. Is the tip all there? Is it intact? You have to visually confirm that the whole thing came out. Because if that tip looks jagged or broken, you have to assume a piece is now floating around in your patient's vein, and that is a catheter embolism, a true medical emergency. Okay, let's circle all the way back to that very first question. The patient with the PICC line, the chest pain, the trouble breathing. We suspect an embolism. This quote here gives us the first clue about what to do. So what's the logic behind this very specific positioning? Here it is. This is the life-saving sequence you burn into your brain. First, you clamp that catheter to stop any more air from getting in. Second, you roll the patient onto their left side and put them in Trendelenburg, head down. Why? This is brilliant. It traps the air bubble in the top corner of the right atrium, which keeps it from traveling to their lungs and causing a fatal pulmonary embolism. While you're doing all this, you're slapping on oxygen and getting the provider on the phone. Clamp, left side, Trendelenburg. That's the algorithm. You know, through every single step we've talked about, from putting the IV in, to managing it, to taking it out, there's one golden thread that connects everything. Asepsis, keeping things clean, the absence of germs. Every time you scrub a hub or clean the skin, you are protecting your patient. This is the absolute foundation of safe infusion therapy. It's your responsibility. So you've got the steps down, you know what to watch for, but great nursing is so much more than a checklist. The real magic happens in your assessment and catching those tiny, subtle changes before they blow up into a big crisis. So my question for you as you get ready for the NCLEX and for your amazing career is this. What's one thing from all this that you're going to watch for just a little more closely? Because that constant vigilance, that's what makes a truly great nurse. You've got this.